Okay. Now, can you see it as a slideshow?
Yes.
Okay. So
Yes, yeah.
what we're going to talk about is basically lung ultrasound in a desaturating ventilated neonate. So I'm going to give you some histories, and then we're going to basically get two of you to work in groups. So we should always work in groups. Now, the reason I want you to work in groups of two each is whenever you're learning lung ultrasound and you're on your unit, you might have more than one person who's skilled in being able to do it. And whenever I'm confused or I want a second opinion, I might go to a second person and kind of say, well, have a look at the baby and have a look at my images and see what you think. And the advantage is two minds work together. You can mentally model and you can really come to a conclusion very quickly. Now, for any baby who's deteriorating on the ventilator, we have a clinical approach. And there's a variety of reasons why the baby might be deteriorating. These could be a problem with the airway. There might be a worsening of the respiratory pathology the baby has. Alternatively, you might have a cardiac issue, might be sepsis like an evolving pneumonia, or it might be sepsis per se with pulmonary hypertension that's evolving, and that you might have no deterioration in the lungs. Now, really, there are other causes, and one of the important aspects that we might want to consider is like you might have a neuromuscular problem where a baby has aspirated. Clearly, if the baby's aspirated, the history of milk would become quite relevant. But when we consider airway problems, in a ventilated baby, classically the ET tube might be down the right main bronchus. This might be a situation where the baby's extubated, and that's why you're desaturating. So you'd kind of go through the dope process clinically, but at the end of it, really, if the baby you've ruled out kind of displacement of the tube. You don't think it's obstructed. The chest wall is moving. And the baby has equal air entry. There's no evidence of a pneumothorax. Then the investigations that kind of come to mind are a chest X-ray or a lung ultrasound, which is your next kind of step. Few things that I would always do is I would examine the baby very cautiously. If where appropriate, I might kind of think of doing pre and post ductal saturations if I'm worried about PPH. And does this baby have heart murmurs? Are we in a situation where this baby has what we'd call a deterioration on the ventilation settings? Like if you're using volume guarantee and your pressures are going up quite significantly, the question I'm asking the nurses is, have they suctioned recently? Have they had secretions up? Is this a situation where the baby might have had lateral ectasis? I might look at my flow volume curves. So all the information that I might need before I go to investigations to kind of try and determine what's wrong with this baby. In our unit, we have a histogram which allows us to do trend analysis, and I find that very, very useful. I think it's something that is really helpful. But really, when you look at the approach, the clinical approach to acute desaturation on the ventilator, you look at what we've just talked about, the history, exclude dope, you would then kind of stabilize. And there's a concept that I call the pit stop approach. Now, the pit stop approach basically means that any baby who's acutely deteriorating, you manage clinically first. So if I detect clinically that I've got a tension pneumothorax on the right side, I've got a baby who's desaturating, who's becoming bradycardic, or who's not got pulses. I'm not going to get a chest X-ray or a lung ultrasound to make that diagnosis. I'm going to needle after transillumination. So really, clinically, what is important is that you're stabilizing this baby. Again, displaced tube, the tubes come out. That's a clinical diagnosis. It's air entry, it's pedicap color change. Have you got end-tidal CO2? Can you see, loops on your ventilator, inspiratory, expiratory loops? So there's some diagnoses that are really clinical. And I think if you're trying to use an investigation to diagnose them, then actually you might actually be doing harm to the baby. However, if the baby is then stable and is still desaturating, a chest X-ray or a lung ultrasound can help. And what it help you diagnose? It can help you diagnose a pneumothorax acutely, maybe one that's not severe enough to cause the baby to tension, but one that is really rapidly deteriorating. And as you know, you can quantify a pneumothorax in a supine baby by actually taking your probe from medial to lateral to try and see where your lung point is. Very, very important. But one of the aspects of your examination and your background history is really how much of a scan do you need to do and what is your point of interest. Now, this comes back to how you perform lung ultrasound. Now, in a baby where I have diagnosed a pneumothorax and I think it's getting worse, I really want to do both the right and left sides. I could have bilateral pneumothoraces. So where time permits, the risk in this situation of saying that I'm just going to do the right side, I can see a pneumothorax, oh, it's big because I've got a lung point that's in the mid axillary line. Let's needle the right side. Well, really, what might be happening is you haven't done the left side. You do the left side, and actually your lung point on the left side is it's in the posterior axillary line. So the left side is actually worse than the right side. And in that situation, really, your point of interest would say that you needle, you manage the left side, or you start inserting drains in the left side before the right side. So it's really important that there are some indications where you need to be performing comprehensive scans. And like when you do a chest x-ray, it's not as if you're going to do the right and not do the left side. So a lung ultrasound is very similar. Just remember that for all practical purposes, we are doing the anterolateral areas on both sides. And when I say anterolateral areas, that's R1, R2, R3, R4, L1, L2, L3, L4. And really what I'd say is that if the posterior sides are necessary, if I can't find any pathology in the anterior sides, I'm really going to do the 5, 6 regions right and left through the posterior axillary line. So your point of interest is very important. Now, clinically, if you auscultate and you find that you have reduced right-sided air entry and the left side is good air entry, then I would start my lung ultrasound with the point of interest, which is the abnormal side. Now, naturally, from our perspective, a simple example that I'll give you is a tube down the right main bronchus. You have reduced right-sided air entry as compared to left-sided air entry. You transluminate and the translumination is negative. Again, because you have reduced right-sided air entry, I would start my lung ultrasound on the right. But if it was reduced left-sided air entry, I would start with my lung ultrasound on the left because I want to start with what I would call as the point of interest. So again, what we're moving to now is we know how to do the lung ultrasound. We know what the abnormal pathologies might be that might explain why this baby is desaturating. We have done the background history, we've done dope, we've stabilized, but we start our lung ultrasound with the point of interest. And once we make a diagnosis, we clinically correlate. And if there's any confusion, we phone a friend. And a phone a friend kind of means that while I'm learning, if I've got a friend there who also does lung ultrasound, I might want him to see the images with me. But if I don't have a friend, then I would say that during your learning phase, you must always back up your lung ultrasounds where time permits with a chest x-ray. And it is the best way to learn because until you become more confident at being able to do lung ultrasound, chest x-ray remains your gold standard. With time, what you'll find is lung ultrasound will become your gold standard for a number of conditions. That will then result in a management decision being made. Always, always, if you decide that you want to you've got lung atelectasis, basal zones at the back, you're going to increase the pressure, you want to recruit lung, really what you need to do is go back in half an hour and check and make sure that that's improved. If you've needled or you put a chest drain in and you know the thorax is getting better, the baby's clinically improving, I would go and put a probe back on to confirm by lung ultrasound that my lung point is anterior, that it's improved, or that, from my perspective, I can see sliding in all the zones, there's no air there. So always, always reassess clinically, but you must confirm improvement with the lung ultrasound. If the baby is not improving and you're confused, just get a chest x-ray. Any questions so far on this slide? Any questions before we move to the workshop? Okay. So what we're going to do is I'm going to give you a history and I'm going to nominate 2 people. So who can I nominate? Who should I choose? So Arif, can you hear me?
Yeah, I can.
Lovely, Arif. Arif, you have Avinash, who is your friend and partner in this. I'm giving you
Mhm.
both a history. I'm going to ask you first, and then I'm going to ask Avinash. Okay? And then we're going to come to a conclusion of what we think has happened to the baby.
Sure.
Okay? So this is the history. This is a baby who's preterm 24 weeks. We've kind of had him ventilated for 2 weeks. His background history is that he's never been extubated during this period. There's a significant history of having preterm prolonged rupture of membrane since 18 weeks of gestation. After birth, he was conventionally ventilated, mainly volume guarantee ventilation. He had a honeymoon period for, I would say, 3 days after that, where, we kind of were able to wean ventilation, but gases kind of prevented us from extubating him. His CO2s were kind of in the 50s to 60s with a pH just above 7.25. And over time, these settings have gradually increased to the point where in the first week of life, he became very sick. We needed to go back up on the ventilation day 5, 6, to the point where we couldn't saturate him at all. And we did an echo, which showed demonstrable pulmonary hypertension. So we decided to put him on some nitric oxide for a duration to see the response. He was a responder. What was interesting is during this period, day 4, 5, his CRP went up to 27. And really, when we cultured him, pretty much we grew E. coli. So we've completed 10 days of antibiotics. Okay. Any
Yeah.
questions?
I think the history is pretty much clear now for now.
Okay,
You can
great.
proceed.
So really, what has happened now is that day 15 of life, this baby's being managed on volume guarantee with 6 mils per kilo. We're needing pressures of 24 to 27 with a PEEP of 6. Now, our FiO2 in keeping this baby stable, as we've just finished antibiotics, we've done a chest X-ray, you know, day 13, which basically looked very much like evolving lung disease as opposed to RDS. The gases were acceptable. We had a pH of 7.25 in the morning with a CO2 of 60. But at 3 o'clock in the morning, this baby has gone into 100% FiO2. We are currently needing pressures of up to 30, actually needing to even relax the VG uh, pressures to achieve what I would say is 6 mils per kilo of volume guarantee. Our saturations pre-ductally and post-ductally are both 80%. There are no heart murmurs on examination. It's okay. At the moment, the air entry is equal. The nurses have done a gas with a pH of 7.1, and the CO2 is 73, which in kilopascals is about 10 kPa for people from Europe and the UK. So that's our situation. What would you like to do?
So I'll just quickly recap
Yeah,
the history. Born at 24 weeks and
yeah,
then rupture of membranes in 18 weeks. So that definitely there should be some element of lung hypoplasia as well, and
okay,
RDS.
yeah,
And as the baby required higher ventilator settings, was on nitric
yeah.
oxide.
The INO's been weaned off after the first
I know.
week. Yeah,
Yeah.
and actually this baby was getting better, but now day 15, suddenly 3 o'clock in the morning.
Yeah. So first of all, given in this scenario, baby is vented and acutely deteriorated. I would definitely like to first look at the mechanical causes, for example, dislodgement of the ET tube, for example, or blockage of ET tube, which is
Okay,
quite
so
common
you have
in
equal
neonates.
air entry.
Yeah,
You have examined the baby, and to a point,
yeah,
you're a little bit confused. Maybe the right-sided entry is so equal air entry this morning, but right-sided entry is a little bit, I would say, reduced at the moment.
at the moment.
Yeah.
And
You don't translaminate. You've
yeah,
no pre and
so
post-ductal SATs difference, no murmurs.
yeah, but they are these SATs have dropped to low 80s.
Yeah,
Yeah, and there is respiratory acidosis in the blood gas.
yeah.
So um, as there is no pre and post, the air entry is equal on both sides,
Yeah,
but still we need to rule out the pneumothorax.
yeah.
And also, I would like to rule out the possibility of pulmonary hemorrhage in this baby.
So there's no evidence of blood up the ET tube. You have good flow loops on conventional ventilation, indicating that the tube is should be in. You've put end-tidal CO2 and you've got a good trace. There's a slightly prolonged expiratory tail to the end-tidal that you see.
Yeah,
Uh, but actually, there are no concerns with regards to the tube being out. So, from a dope mnemonic, the only thing is the right-sided air entry is slightly reduced.
yeah.
So what would you like to do a lung ultrasound?
Yes, definitely.
Okay. So just
Looking for any collapse or consolidation.
okay. So possibly looking for a collapse and consolidation. Avinash, anything else that you would like? Anything in the history or anything that you like to do that I haven't talked about?
Um, thinking whether it is just a deteriorating RDS or is there a infection, collapse, consolidation with
So
the CRP rising and the respiratory acidosis, as Arif was saying.
beautiful. This is beautiful. So, guys, for all of the 14 people who are here with me today, what Avinash is doing is classically what we call mental modeling. He's thinking of the history and thinking of his differential diagnosis. And I want you to do this every time before you go into your lung ultrasound. You kind of don't feel there's enough evidence for pneumothorax, but this is a baby who's previously had E. coli sepsis. So, very much this is what we did in this baby. I asked for the baby to be screened. I asked for antibiotics to be restarted in this particular situation. I told them to organize a chest x-ray, which takes time in our department in Southampton because the radiograph has to come in from across the road. And really what we decided to do in that situation was I came in and we did a lung ultrasound. So now I'm going to give you the lung ultrasound. So Arif, this is L1.
So in L1, so there is I can see three ribs.
Yeah.
There is pleural line is visible, but I think
Yeah.
there is some lung sliding. I can appreciate, isn't it? Yeah.
Okay. Good.
I couldn't appreciate any A lines,
Very good.
and there are some B lines, not significant.
Okay, that's good. So Avinash, you going to help Arif?
Yeah, the pleura is clearly visible and the batwing sign is there. There seems to be mainly B profile. A lines are not visible that clearly. The lung sliding is there, I would say, because you can see the some comet tails, some B lines moving across the pleura. So I think pleural sliding is there. So it's mainly a B profile lung
Very good.
uh, with with consolidated B lines. I would say this is either RDS or
Okay. Beautiful.
consolidation.
Beautiful. So what I would say is just coming back from the last, we're going to look at all lung regions, then comment. So
Yeah,
save it for all lung regions because really what we should always do is we mental model, but we look at all lung regions. So let's, I'm just going to say that L1, L2, L3, L4 were all very similar. They're just exactly like this in the
yeah.
interest of time.
So
Okay.
if it is generalized, then RDS becomes more of a possibility rather than consolidation in
Very
one
good.
particular region.
So kind of, in this baby, if I look at the left lung and say that that's the pattern that I see virtually everywhere, RDS in a 15-day-old baby, I mean, you're probably saying it's, and this is where I
As
would say that
homogeneous sort of lung pathology,
very good.
which in keeping with the history of PPROM from 18 weeks, uh, would be um, underdeveloped lung.
Yeah.
Uh,
So evolving lung disease, and this is where this is a really important thing for us to discuss. We have just not defined the transition zone between RDS and evolving lung disease. And this kind of arbitrary definition of saying that BPD should be defined at 28 days and that chronic lung disease is defined uh, I think is going to change very much with the evolution of lung ultrasound. I think this ability to kind of, and Almedina will speak to you about this in a lot of detail, and how we probably need better definitions of how we think lungs are evolving in terms of lung disease for the extremely preterm baby. But I completely accept what you're saying. I think for me, negative history is also very important. No fractal sign. So again, no areas to suggest atelectasis in this particular, it's more like a whiteout kind of an appearance. And if you see this in all areas, basically your left lung is very white. Now, for a baby coming to 2 or 3 weeks, This could be a PDA opening up as well. My only point against it's very acute deterioration. So, which kind of goes against, but a pulmonary hemorrhage acutely can give you this kind of presentation. We're only looking at one lung at the moment. Now, let's make this a comprehensive scan and look at the other side. I'm just going to take my, sorry, really irritating with the laser pointer. So this is the right side. So Arif.
Yeah. So this right R1, this one, right?
Yes.
So I can see two ribs over there with a clear pleural line, but lung sliding appears to be absent.
Yeah.
There are no A lines.
Yeah.
And so there is some element of looks like some consolidation here.
Where? Here?
Yeah.
Lovely. Well done. Amazing. That's great. Okay. So you have, so you're absolutely right. Avinash, what do you think?
The pleura is not continuous. There is a break in the pleura there. Yeah, where you're pointing, and then there is pleural consolidation there.
Yeah.
Yeah.
Quite a large
Just
area.
making sure it's not like a linear probe going on to some other area.
Yeah.
But yeah, there are ribs on the top and appears to be in the intercostal space still. So
Beautiful.
yeah.
So right upper lobe consolidation. Now, do you remember when we spoke about collapse and consolidation? We kind of, how do you differentiate? So with consolidation, it should arise from the pleural line. And can you see a pleural line over here?
No,
Okay, so
No,
if no pleural line, is this aerated or not aerated?
not aerated.
not
So
aerated.
not aerated, and you've got consolidation here, but you've got these static air bronchograms. Can you see these
Clear
small pinpoint?
bronchograms.
Yeah.
Yeah.
Yes.
So do you think this is atelectasis with consolidation or just consolidation?
Looks like
Consolidation is atelectasis. Yeah.
atelectasis.
Okay, yep. So this is consolidation with atelectasis. The reason is you have got no pleural line.
So would
It's
Doppler help in this case?
it would. So if you have no aeration and no lung tissue, will you have any blood supply there? No. So
No.
if you did Doppler this region, basically what you'd see is no blood flow there. Again, with the consolidation, what I'd say is that just be careful because I can't see a fractal sign over here, and really increased blood flow in this area would be indicative of infection. But consolidation itself could be indicative of maybe early infection. Okay. Now, what about R2? What do we think of R2?
Yes.
So, Avinash, you go first this time.
So you can see the ribs and the batwing sign. It's mainly B profile again. Can't see the A lines. It's homogeneously sort of B profile in all the four intercostal spaces. So again, there is no subpleural freckling, and it appears like again either RDS or
It's a very homogeneous appearance, like evolving lung disease. Yeah. And if I said that this is what we saw in R3, R4, pretty much the back of the lungs is just completely white. So it's a very white out kind of a lung, very homogeneous kind of a lung. There's no evidence of pulmonary hemorrhage. So other than this area of focal consolidation with a little bit of atelectasis in that right upper lobe in a baby who's acutely desaturating, what pathologies have we excluded? Is there evidence of a pneumothorax?
No pneumothorax.
Okay. Is there evidence to suggest any kind of fractal sign or acute mnemonic consolidation?
No.
Okay. Is there widespread atelectasis of both lungs that needs recruitment?
No.
Yeah.
Widespread atelectasis of both lungs that needs
No,
recruitment?
no,
In right upper lobe, but there is
Not
not
widespread.
widespread.
sort of homogeneity in the rest of the
Sure. So
lung.
is there a possibility that this might be meconium aspiration?
No.
No,
No.
because of the age.
That is quite
Yeah, it's
homogeneous.
crazy.
Given the history, no.
Yeah, it's crazy. Yeah, Dr. Sharma can sometimes be crazy, brings up crazy stuff. He's a crazy person. Okay, but just in terms of, could this be infection? Early
Yes,
infection?
Yes.
it can be.
Possible.
Yes.
Okay.
Chances of being
Could this be mechanical obstruction secondary to secretions?
Yeah.
Yeah,
Okay.
it could be.
Okay. What else could it be? So right upper lobe collapse consolidation. What other things cause a right upper lobe collapse
You
consolidation?
need to see the tube position where
Lovely, lovely. Okay, now this is not this baby. This is the reason I'm showing you this is to kind of give you a feel of what a fractal sign looks like. So this is a fractal sign for you, okay, where you have a very irregular line. The reason I wanted to kind of show this to you is this would favor a mnemonic kind of a presentation. So you can see the pleura kind of there and just a very irregular margin at this particular point. Now, for those of you who know how to look at airway ultrasound, and we'll teach you this, this is the arch of the aorta that you see here with blood coming flow. And this is your ET tube. So this is your endotracheal tube coming in from the left over here. There. Can you see it?
Yeah.
So I'm just gonna
yeah.
freeze it for you as well so that you can see it. So this is the aorta. These are the branches of the aorta. And that is your endotracheal tube coming through. Now, normally your endotracheal tube in an extremely preterm baby, this is usually where you find the RPA. It should be half a centimeter above the RPA, usually at the upper margin of the aorta. This is way in. This is really down the right main bronchus. So without doing an X-ray, we've kind of diagnosed that this is basically a right main stem bronchus intubation. So we pull the tube back, and this is the X-ray before we pull the tube back at the bottom. And this is sorry, not the X-ray, this is the lung ultrasound. And the image at the top is basically an image after about half an hour of having pulled it back. And what you can see, R1, is now you've got an slightly established pleural line. You've got lung that's better recruited. So with pulling the tube back, you've basically been able to recruit the lung. You can, from your perspective, actually see the tube being pulled back here in real time. So that's your tube. So just keeping your image there, the tube is just going back in real time over here. So you can actually measure how far to pull the tube back by using ultrasound. But be very cautious. This needs a lot of skill. And really in extremely preterm babies, I'd be very cautious. I'd be doing it looking at the markings. Now, you could argue that you can actually make this diagnosis by just looking at where your tube is at the position of the lips. But in extremely preterm babies, even a half a centimeter can make a big difference. So this is just an example of how we've used lung ultrasound alongside airway ultrasound. So this is just verifying the tube position again, now that we've fixed it. So really what you can see is the tube coming in there. It's a half a centimeter above the level of the aortic arch. And that is the ideal position in extremely preterm baby. About a centimeter from the RPA. The RPA comes in here. So really pulmonary
This
artery.
is in the premise. In term babies, it's not the calculation.
So usually say about a centimeter in a term baby. It's a half a centimeter in a preterm baby. There are nomograms for it that have just been published that I'll share with you at the end of the course. But can you see how I would say that mental modeling is quite crucial and really using your differentials? This could still be infection. I think, in situations like this, treating with antibiotics until I actually know that's the case would be completely irrational. This could still be a early mnemonic consolidation. But I've got more information after I've come in using the ultrasound to help me. Does that help? Any questions?
Yes, Dr.
Yeah.
Alep, you can go to the R1 again, please again. R1. Yeah, there is no R1, the last slide. This one. There is no here some pleural fluid here.
Over here?
Yeah,
No,
this one.
no,
There
no.
in R1 here.
I'm
Yeah.
basically what is happening is I'm not getting very good delineation. What I can say is I can't see an established pleural line at all, and I can see this area of what I would say is consolidation with absence of the pleural line. That's not fluid.
Okay.
Yeah. And the reason, we know it's not fluid is this is later on. So after the recruitment, what you can
This one, just below the broken bolora, في some anechoic fluid. This here, up.
no, that's
Yeah,
not fluid. So having done the scan, I can tell you it's probably a little bit of artifact. What you can
yeah,
classically see here is lung pulse.
yes.
Yeah. So that's lung pulse. Can you see that in an atelectatic area that's being recruited? So rather than sliding, you can see that kind of heartbeat that's being transmitted. Again, just, I mean, to give you a feel, to have such a focal area of effusion, I mean, clinical correlation is quite crucial in situations like this. Why would I have such a if I think mentally that this might be a pleural effusion, it would be highly unusual in a baby that's supine to find such a focal pocket of effusion, while the rest of the lung, especially the lung bases, where you expect fluid to accumulate, doesn't have anything. So
Yeah.
again, just it is all about clinical correlation in situations like this. Uh, okay, so now we're going to give you another baby. Who are we going to choose for this? Anybody want to put your hands up?
Dr. Alok, one query.
Jay?
In the case which we just discussed in
Yeah,
R1, there was no pleural line seen in the
yeah,
area which was consolidated in atelectasis.
yeah.
So, do we call it as B dash profile or it's not like
So
this?
you're right, it is a B dash profile. You're right, because there's no sliding. The reason why we kind of avoid using, actually here, there's no pleural line to determine sliding because you have no lung aeration in that area.
Yeah, but the other part of that R1, I think pleural sliding was there. Lung
Yeah,
sliding
yeah,
was there.
because when you have a right mainstem bronchus intubation, you
Well,
use
I'm
your
here.
you lose your right upper lobe, but actually the mid lobe might be preserved. In some situations, I mean, we've had a case which I'll share with you later on, actually. That's a case for a different time.
Okay.
Yeah. Satish, please go ahead.
Sorry, Alok, you wanted this volunteer for the second case, so
Oh, that's
I'm
so
happy
kind
to.
of you. I'm so grateful. Yeah, please. And to help Satish, I'm going to nominate Jafar. Dr. Dr. Jafar, Dr. Khan. Okay. So Jafar might not have audio. So Surjit, are you happy to help Satish?
Yes, Dr. Alok,
Okay.
I'll do that.
So this is a term baby. The history that we have in this particular situation is a baby who had very severe oligohydramnios from 13 weeks of gestation. This baby had congenital problems. We've had hydrocephalus diagnosed on the anomaly scan, very severe. And really, the overall kind of feeling for this baby was quite pessimistic in antenatal counseling. But after having spoken to the parents were quite keen that we give this baby a chance and that we see how the baby responds to resuscitation, and that any decisions with regards to kind of direction of care should be done depending on the response to resuscitation. So this baby was born at 36 weeks after a normal vaginal delivery. The baby, from our perspective, was intubated and ventilated at birth because he had very poor respiratory effort and was bradycardic, responded well to inflation breaths. The heart rate came to above 100, but saturations at 10 minutes were about 50 to 60% in this baby with severe hydrocephalus. The baby was not kind of saturating in even 100%, so had a dope done. And actually, there were clinical concerns that this baby had a left-sided pneumothorax. This pneumothorax was transluminated, uh, positive, uh, and the baby had needle thoracentesis in delivery suite, followed by move to the neonatal unit. Uh, an initial chest X-ray after kind of sighting lines and doing some golden hour management basically showed a persistence of the left-sided kind of tension pneumothorax. So the drain was manipulated. And actually, at 2 hours of age, we have a baby who has saturations of about 85%. Now, we've just done a chest X-ray and she's just left. The left-sided tension pneumothorax repeat at 2 hours of age shows improvement. The right side has a picture of what I'd say is a very bell-shaped chest with what looks like severe lung hypoplasia but predominant RDS. Now, as the lady has left, 2.5 hours of age, this baby's saturations have dropped to about 50%. Satish, would you like any other history?
No, that's I think good enough, Alok. Thank you. I mean, it's essentially in acute hypoxia in a baby who's 2 hours old in a setting of severe lung hypoplasia and hydrocephalus, left tension pneumothorax, which is drained, and baby still hypoxic at around 2.5 hours age. I think repeat chest X-ray is awaited, if I understood correctly.
So
And
the repeat chest X-ray after placement of the drain shows that the left-sided pneumothorax is better. The right side shows a picture of RDS, but there's significant lung hypoplasia. You know, you have about 6 ribs. At the moment, we're kind of in a situation where this baby is ventilated on quite high pressures. So
yeah,
we were using pressures of 35/6. The baby was paralyzed, sedated by that time. We had some morphine on board. We'd started some inotropes empirically, kind of to help a mean blood pressure of about 35. Just pre and post ductal saturations are similar, the same. They're 50% now on both sides. There are no heart murmurs to be heard. And transillumination at this particular point shows left-sided transillumination. The baby's quite edematous. You know, he's got severe hydrocephalus. It's a little bit tricky with transillumination.
Yeah. What's the CO2's,
Yeah.
Alok?
So at the moment, pH is 7 and the CO2 is 88, or the equivalent of about 12 kilopascals.
So we are essentially in acute hypoxic respiratory failure. We are neither oxygenating nor able to clear the CO2.
Yeah.
Mentally, while I'm kind of thinking is it's hypoplastic lungs. So there is a good recipe for pulmonary hypertension here. And also we are unable to even clear the CO2 because of the severe lung hypoplasia. To make the matters worse, there is pneumothorax as well as RDS kind of picture on the right side.
Yeah. So let's say that the radiographer has just left. So you are going to perform a lung ultrasound. So just protocol. So what kind of a scan are you going to do? Are you going to do a limited anterolateral scan? Would you like to do a comprehensive scan?
Obviously, as the baby is so extremely sick and severely hypoxic, I think it needs to be a focus scan to begin with. Ideally, one needs to do full scan, but I don't think that's the time and place at this point. So we need to address what information we can glean from the ultrasound on top of the existing clinical as well as from the ventilatory loops and graphs and the X-ray to aid the management.
Lovely, that's beautiful. So just on that, so let's say you start with anterolateral because the baby's supine. Just what's your point of interest? You're going to start on the right or the left side?
So chest X-ray has had left tension pneumothorax drained, and the right is RDS kind of picture. I think I probably would start with the left.
Okay, lovely, beautiful. That's lovely. Can I ask, would you like to do an echo instead? I mean, this baby might need nitric.
I was tempted, like I said at the, previously, with my, I would have tempted to do both the echo and lung ultrasound to get a full thorough assessment. But obviously we need to stabilize the baby from the breathing point of view, then move on to the cardiovascular assessment to ascertain the underlying, pulmonary hypertension, etc.
Okay, that's great. So these are the images. I'm showing you the right side first. I did the left side first. So, but I'm just for time. So Would you like to talk about them, Satish?
Okay, R1, obviously we've got the bat wing sign, 3 ribs at least, and the depth is about 3.5 centimeters. So in a term baby, that is good. I can see A line, but I can see truck sign here. I can't see neither B lines or comet tails, comet artifacts, I should say. So there is an evidence of air leak.
Very good. Now we're just looking to quantify this air leak, see how large this is. So this is R1, this is R2, R3 actually. So that should be labeled R3. I apologize. Yeah. So R34. So if that is R34, what do you think?
It is fairly, I mean, even R3, R4. So it's both anteriorly as well as laterally, isn't it?
Yeah.
That means so, and I can see we've got the liver shadow coming in there.
Yeah.
You going to, that's R5, I take it? Is it
That's
R4, sorry.
R4 posterior axillary line. So virtually R5, you could say. So what do you think about that?
There is now I can see some sliding there. Am I? Yeah, I think so, because there is some, yes, there are some B lines. Yes.
Very good. Very good.
Yeah.
So what you can see in this area here is you can see a comet tail.
Yeah.
There is lung sliding there.
Yeah.
And
Yeah.
there's no lung sliding here. I apologize
Yeah.
about the quality of the image, but this is the challenge of doing scans in sick babies when you start getting into the axilla. Now, what is very important, guys, if you're in this situation, get them to abduct the hands. To get the axilla, to get your probe continuous, to get good quality images, you need the hands abducted. And really what I'd say is that this is where you can see your lung point coming through. But I'm virtually R5 posterior axillary line. So there's a large anterior pneumothorax, lateral pneumothorax, and actually extending to the back. So significant pneumothorax. Okay. What about the left side?
Okay, left side. I'm trying to get my head around it. So,
yeah. So this is R1, this is R2, and this basically is R3, 4.
So is it the left, Alok?
Yeah, this is the left side.
So that's L1, L2. That's L1, I'm assuming.
Yes, very good. You've got thymus.
Yes. And there is a obviously there is discontinuous pleural line. I can see sliding there.
Yep.
And there is a I could see a line.
Very good. So L1, L2, as you move down, I think what you're seeing is lung pulse there.
Okay.
As opposed to sliding. So what are you going to do to help you? What is going to help you? Very good. So if you put the
M mode, you could do the M mode to see what's the barcode sign or stratosphere sign will get there.
So when I put M mode on this, I got a barcode sign. So basically there's air anteriorly at this particular point. But really when I go to L3-4, what do I see?
I mean, L3, L4, you can see obviously B lines. So you essentially ruled out significant air leak there.
Yeah.
So that means air is only anterior. It's residual anterior air leak following the earlier intervention.
Yeah, very good. So what would you like to do?
Okay, so we've got a right anterior. There is a slight residual pneumothorax. ET tube is high. Okay, so obviously first things first. So we would want to make sure that the ET tube is in the optimal position and secured correctly. I would drain the right anterior pneumothorax as it is large and baby still desaturating in front of us. And then do a thorough cardiovascular assessment with a view to get the severity of the pulmonary hypertension and take it from there.
Lovely. That's beautiful. So just giving everybody a feel, this is where the pit stop approach comes into concept. This baby has already got a left-sided drain, will need a right-sided needle thoracentesis, will need a right-sided chest drain, will need a follow-up X-ray, you probably need an echo. And really, in my setup, at least in Southampton, used to take them 20 minutes to just run the nitric through. I think the risk of pulmonary hypertension still remains very high. I'm going to do the echo, but what I can do in the interim while we're placing the drains is get them to run the nitric through, basically prepare the machine after this, order the echo, so that really once I've done airway breathing, and this is the pit stop approach. It's airway breathing circulation, and that's the order in which we're going to stabilize these babies. But that is what Satish has described really, really nicely. So these are just two cases where we haven't done chest X-rays, where really, from our perspective, we have used lung ultrasound to change our management. Now, you could argue, let's do an echo. And I did an echo in this baby after the chest drains were in, and the duct was shunting completely right to left. We had severe pulmonary hypertension. We put this baby on nitric. Now, the problem, if you have residual pneumothoraces and a very large pneumothorax on that left side, and you give this baby nitric oxide, it will basically replace whatever air you have in that pneumothorax and make it much worse. So again, just a good example of how lung ultrasound or point of care ultrasound can help you. That brings us to the end of this session. Any questions?
Yes, Alok, I totally agree with you about definition of BPD. Should after ultrasound interview should be diagnosis since 10 or 14 days after birth. Not to wait till 28 days or 35 days a week.
Okay. That's so kind of you, sir. Any other questions? Anything before? That's our 90 minutes. Yeah.
Look, I just wanted to ask, can you show us again the air bronchogram, how to
Can I
locate them on ultrasound?
show it to you, because I'm going to do RDS on Sunday. We will have a lot of really nice images.
Oh yeah, definitely.
Yeah. Lovely.
Alok,
Yeah.
Alok, one question, if I may.
Yeah, please.
Because I think in the very initial sessions, I think I thought if you have to change the position from anterior to posterior, one has to wait minimum 30 minutes of
That's
such
true.
kind of.
That's true.
But obviously, in this scenario where you know what you are likely to find, like the mental modeling, so does that still apply?
So that's a beautiful question. So what I'd say is this is the acute situation with a desaturating baby. If I am going to do a comprehensive scan with the baby supine, and especially with drains in, with babies who are in, I don't want to move them. So I commonly use the posterior axillary line to look at R5, R6, and L5, L6. But I do it with the knowledge that this baby's not been turned. So if I get an increasingly wet B profile, I will clinically correlate. Now, if this is a baby that's getting worse, where I see widespread atelectasis, that's lung that can be recruited. But naturally, from my perspective, I would also know that the posterior parts of the lung in a supine baby are difficult to recruit. So really, if I'm increasing pressures and I'm looking to see that the pleura gets established and I recruit that lung, I would also be cautious because there might be normal anterior parts of the lung that get over distended and you can pop. So what is very important is that you take into account that the baby is supine and that you haven't been able to move the baby. So I would take that into account. And a good example is with TTN babies, the backs of the lungs are usually poorly aerated and very wet. So they often, we talk about lung ultrasound scores in these babies in the posterior regions, they're always high. Now, the question is, if I've got a double lung point and I've got transitioning aerated lung, really, I've got bad B profile with whiteout at the back, and I'm doing the supine areas and I don't want to disturb this baby, then really what I might do is do another scan, maybe in a few hours. And if I still see better aeration in that area, that whiteout B profile has become kind of an AB profile or a double lung point, I know that clinically the baby's getting better. That's how I'd clinically correlate. I wouldn't necessarily put the baby prone just to get better images to satisfy that 30-minute rule. Does that help? Does that answer the question?
No, no, no. Thank you. Thanks for that clarification. Yeah.
Yeah. Lovely. I'm really grateful to all of you. We will have what I would say is a really good interactive session on Sunday, where we'll be talking about lung ultrasound scores in particular, and RDS and TTN, and really the management aspects. We'll also be discussing 2 more cases. So it's all clinical correlation. It's all very interactive from here. God bless you all. Thank you very much.
Thank you
Thank
very much.
you.
Thank you.
Yeah,
Thank
thanks,
you.
Alok. Thanks.
Thanks a lot.
Thank you.
Thank you.
Have a
Thank
good
you,
evening.
Mr. Palak.